It gives me a real pleasure to introduce our guests today. So just to say straight up, I'm ably assisted here by my colleague Juanita Guidera, who's going to join the session, and she'll be joining us in the conversation and with some questions as we go along. And then a special welcome to our first guest of the autumn series. That's Dr. Veronica O'Doherty. And Veronica is a consultant psychologist and has a long experience working at Tallaght University Hospital. And you can see there on the slide, Veronica has lots and lots of experience in psychology, and we're gonna tap into that today and talk about it. So Veronica, you're very welcome. I'm gonna. You're muted there still. It would maybe just after the. I can hear you now. Great.
To everybody, and thanks, John. I hope you can hear me clearly now.
Yes, absolutely. So Veronica, thank you for joining us today. It's a real pleasure to get to meet up and to talk again. And just I suppose I was looking at your biography there. It's on the slide, but you obviously have a lot of experience as a psychologist, but you also worked previously as a staff nurse and worked in intensive care, and maybe that's a place just for us to start our chat in terms of, for you, how has that kind of framed your experience, as a psychologist, and especially as a psychologist who's worked with staff?
Well, I think it's hugely framed my kind of career choices in my life, from being a student nurse in Bagot Street and sitting at the edge of a bed chatting to a patient, and Peter Taff, the matron at the time, who was the first nursing chief officer in Ireland, tapping me on the shoulder and me nearly jumping out of my skin, as we did in those days, and she telling me, stay where you are because you're doing some good work. I get somebody who isn't. And, all through my life, I suppose, lessons of compassionate care and listening to patients really kind of fueled my interest. And I was accepted to psychological training in UCD, basic psychology degree as well as nursing. So the two were always together. And I'm sure many nurses today would say psychological care is still one of the biggest tenets for, well-being for patients and for staff.
And for staff, of course, yeah, and of course the well-being of staff is, I suppose, ultimately what leads to the well-being of patients.
Absolutely, and all the research points to that when staff are functioning at their most optimal and feel good coming into work and feel, good enough and happy enough that it's better for patient safety in general.
Yeah. And I think one of the things when we start to think about this session today, was in patient safety. I think over the last number of years, there's been a move towards more positive kind of approaches to safety and moving away maybe from simply being reactive. And I suppose that moves away from just reacting to what are the practices that can make us safe, and does that kind of make sense to you as a psychologist?
Well, I think even as a psychologist, there's lots of research behind all of that. And, as we talked about even prior to the session, it's not to deny the negative. We know as human beings, we default to the negative mode. So sometimes we have to make sure that we find that balance where we're also able to see the positive, because, ruminating on what doesn't work isn't useful. Being practical about what doesn't work is helpful, but constantly ruminating, and we've all experienced the lunchtime talks where we meet and have the coffee and the sandwich, and everybody's given out. And sometimes what that does is that impacts on the head, it impacts on the body, the mind, and we it's creating a negative energy. So it is about trying to remember that, hang on a minute, what actually did work well this morning amongst all that lack of resources, usual stuff we all give out about? What worked well? And reminding ourselves to also focus on that. It's really, really important. And to see the things that are actually working. And sometimes I think you sent me a little paper there on looking at, those aspects of things that are vicarious, that we come across, that are examples of positive practice. And if we don't have that mindset to be able to see that, we might miss those things that improve patient care and supports us in our daily jobs.
Yeah, absolutely. I think that paper was from Adrian Plunkett and Emma Plunkett, who are people who set up the Learning from Excellence kind of group, and I think again that's a really nice example of again that the purpose here is about achieving safety, but it's about focusing on all the things that go right every day and all the good practices. And I suppose there's generally way more of those than there are things that go wrong.
And to
And
get into
so,
that kind of mindful kind of state of being, and that's not, to go around like a Buddhist monk 24 hours a day, but it is about learning to stop occasionally and see what's going on around you. And, you used the phrase when you welcomed everybody today, just, take a moment, take a breath, get grounded, feel the body, get out of the head and be present. And then you can see what's going on. And that helps to stop reactivity. Even that little exercise that Joan Halifax created is really useful.
yeah, and I think again we probably don't do those things kind of as a habit at work. I mean, I think we're so busy responding, from moment to moment that it's trying to create these good habits, isn't it? Of
Yeah, and
stopping.
even that's exactly it, John. And to attach them to handovers,
Yeah,
and meetings. Like it doesn't, 2 minutes and to do a practice doesn't really take from people's time. And
yeah,
if leaders lead out on that who are convening meetings or starting handovers, anyone can do this, and usually different people might take turns chairing these things, or so of everybody who has responsibility. And that's about really one of the things that it regards to compassionate leadership. It is about the whole team taking responsibility for this.
yeah. That's that's something I think that we put at the core of a program that my colleague Peter Lackman runs at the College of Physicians, but I've some involvement with it too, called the SAFE program, Situation Awareness for Everyone. And again, that opens with the question to everybody at the huddle. So it's very much based around the huddle. So short, 5-10 minute meetings. And the first question to the group is, what have we done well today?
Yeah, yeah. And that's
And then,
really important.
yeah, and how have we kept people
Mm,
safe?
mm. And I think, safety is about inclusivity and having diverse teams. So it's sometimes, if we're all coming from a homogenous kind of groupthink, that stops people speaking up and saying, look, maybe I'm a little bit concerned about this piece here. And allowing that conversation to flow without a blame culture is so important. And using those, we're human beings, errors happen, using those errors for learning moments. And so people are not afraid to say, look, I was doing it this way, but I wasn't so sure about that. What do you think? And
Yeah,
having that led from the top down is so important. And bringing, being able to bring your own sense of vulnerability into the workplace, and naming, and I'm using the word suffering because I actually like it, because I think patients suffer with pain and with you know, disfigurement and all sorts of things when things happen. And all of us are going to be patients at some stage. And hopefully, you know, it's about stepping back and really looking at how did that situation yesterday affect me?
Yeah.
And you know, we work in the acute system. We see people die every day, and I think it's so important to be able to say, do you know what, that was really hard yesterday.
Yeah.
And it doesn't mean everybody jumping in to fix that. There's no fixing of that. That's about
Yeah.
just allowing that to be and bringing compassionate listening and care. And just, you know what, we care about you, that you had a hard session yesterday or a hard encounter with a patient or with a staff member or whoever.
Yeah, and I think we're so, I suppose, focused on fixing things often that we forget, you know, that it's okay
Mm.
to maybe look at the things that can't be fixed, and to you know, to spend some time just you know, I suppose, reflecting on that.
Mm. And that lovely kind of, you know, technique in kind of mindful self-compassion, where you bring your hand just over your heart and you can ask yourself when you're having a moment of distress, even if it's at the bedside, well, you know, what do I need right now that will help? Maybe I need to step back and ask another staff member to take the reins here, or maybe I need to just do that groundedness for 30 seconds, 1 minute, and then ask myself, what is the purpose? What am I here for? And then think about the patient or the other person that we're having this encounter with, and just putting ourselves in their shoes and saying, well, what is this like for them? And really asking, okay, what what can I do under the circumstances? And remembering that as healthcare professionals, we can only bring the skills that we have to the table at that time. We can't do everything. And that's why we work in teams. That's why we have other people there. And that's why even the patient contributes to their own care. And it might be about asking and saying, look, this patient is on maybe a chronic disease trajectory and they're having a, you know, a really bad exacerbation. And maybe those exacerbations will increase over time, or maybe they won't. But it is about saying, do you know what? I know you're in a bad space right now, but we will do our best to minimize the impact of that. And it is about realizing that you're not responsible ultimately for outcomes, because illness and people are complex. And there's a whole kind of myriad of variables that come into the picture, that they're not all your responsibility. And I think
Yeah.
as healthcare professionals, we take that responsibility so seriously. It's part of our ethics, it's part of our code, our DNA nearly. And I think we have to step back a little bit from that and realize I can just bring my best self to this
Yeah.
moment, this procedure, this encounter.
I think that's something we learn, isn't it? I mean, as we go through, and it's something so important, I think, for people
Mm,
in more senior or more experienced positions to model and to
mm,
show people the way, because you know, it's not necessarily explicitly taught to us.
mm. That's right. And don't let me go before I just want to read a very short thing at the end of our conversation by David
Okay.
White on vulnerability that I think is really powerful
Yeah.
on that point.
Okay. We'll come back to that.
Mm,
Um, I think one of the big kind of phrases at the moment in patient safety and in teamwork in general is this concept of psychological safety. You know,
yes.
and having kind of, you know, that belief that you know, if you speak up, you know,
Mm,
that people will, I suppose, respect that and listen to you, and that you won't be kind of ostracized or laughed at, or um You know, that sounds really nice, but I think one of the challenges with it is that it's actually very hard to do. And how do you think we can help people to do that?
I think you're right. I think it is harder to do than everybody just singing from the same song sheet. But I think the payback is huge. I think allowing positive conflict is one of the things.
Okay.
Um, you know, and again, you know, modeling that as leaders and senior people on teams. I think diverse teams help. And it, you know, this sometimes does take a little bit of time because if you've got different views from all sorts of different professions coming in, it you do need to give the space for that. But the time saved in the long run and the impact on health and well-being, sick leave, burnout, all of those things have been shown to drop when compassionate culture comes
Yeah.
into an organization. And no
Yeah.
better man than Michael West to lay out the how to of that. And I don't know if you can see, this is his book, Compassionate Leadership, and, you know, highly recommended. Lots of exercises on team building and how to do all of this stuff. It's a how to do manual, really. And the research that is interwoven through its pages is really strong.
Yeah, I mean, I think many people in this country are familiar with Michael West and his work and again, you know, like psychological safety, it's often seen as something nice and soft, but in many ways, if you listen to Michael West talk, you know, it's anything but in terms of it's a very difficult and something that requires great courage, I think, to bring forward.
Absolutely. And I think, you know, if I, you know, sometimes when I hear people saying that psychological skills are the soft skills, I kind of smile to myself and think they're absolutely not. They're the hardest thing to do.
Yeah,
You know,
yeah.
it's the opposite of soft. And it does take courage, but if everybody supports people who put themselves out there to bring some of that in a safe way with everybody else, then you start to change culture.
Yeah, yeah.
An interesting point coming up there just in the chat box, just about a definition of positive conflict. Could you maybe speak a little bit about that, Veronica?
Well,
Yeah, thanks, Vanita.
thank you. It's really something simple. It's about, you know, not focusing on blame and allowing somebody to have a difference of opinion and teasing that out to try and find a solution. And, you know, the solution may not be what the initial person saw that as being they wanted something changed, but it might be something in between. So it's allowing that space to reach a reasonable consensus within a team or a group and not being afraid to have a difference of opinion.
And I suppose this is if you do have psychological safety, you will bring about, you know, differences of
Yeah.
opinion. You know, and you'll hear about them because I suppose differences of opinion are always there. You know, it's just maybe often, you know, we don't want to raise them because maybe we're afraid or you know, we think people won't take them seriously.
And, you know, look, the examples and very interesting to look at all over the world is negotiation. You know, that's what positive conflict is. It's Northern Ireland, it's Palestine, Israel, it's what's going on at the moment. Um, and often, you know, people would see some situations as just not workable, but it takes effort and time. Um, and creating this in a healthcare setting, which is a different, very different from those. But I think there's a lot of learning we can get from those situations. I was listening to some podcasts there from Daniel Goleman on who writes about emotional intelligence, and he was interviewing a guy who was a key person in he had a psychology background, but he kind of found himself into this whole world of hostage negotiation in, of course, America, where, you know, people were, having difficult situations and putting people at risk. But it's really fascinating, and I will put some of those links to listen to if anybody's interested, because there's huge learning for all of us in some of the findings, and it's certainly huge learning for leadership examples.
Yeah, there was a wonderful book a few years ago called Compassionomics, which came from, again, two kind of American physicians who again weren't coming at this from a softly point of view. It was very much from showing the both hard medical outcomes in terms of you know, pain relief and you know, survivorship and you know, from you know, the use of compassion in the workplace, and if people practiced, you know, compassion in terms of how they communicated with patients or with colleagues, there was real hard measurable benefits from doing this. And how do we convince people, you know, to, you know, and certainly in leadership, you know, to give us the time to do this, to allow us to train people in this, and then to spend the time kind of practicing like this?
Do you know what? I think if you kind of walk the walk and talk the talk, it spreads. It's contagious. And soon, you know, if you're in a team and a workplace where people behave in a compassionate manner towards you, with kindness, with listening, with attention, and you start then to see this is worthwhile, and you start to do that to others, it spreads. And then people want to come and work in that team. People hear about that team. Oh God, that's really nice. Or that place is a really nice place to work. And patients feed back. And it doesn't change outcomes for patients in terms of disease, but all of them will report that they felt a lot better.
There's
Yeah.
an interesting point in the chat box, just from Beatrice Gil Perez. Just people, staff can be caring, helpful and present for others when they're in a good state, when they've already been kind to themselves as humans and see the value of it. Then they have the resources to give care to others in a positive way. I suppose the big question is, what happens when people aren't in a good state themselves? You know, when staff aren't in a good place, they maybe have something going on at home, or they have a very difficult situation. How do you apply this, or what tips or advice would you have for people for creating a psychologically safe team where people maybe aren't in a good place?
Well, I think noticing that a team member isn't in a good space. And, you know, it's not always written across their face or their body. It is about maybe they're missing meetings, or there's something going on, or they're avoiding certain things. And you just know there's something. And it's about asking that question: how are you? What's going on? Is there any way we can help? And I think the going back to the pandemic, even though we're all allergic even to the thought of it, and it is still ongoing, per se, in a different format, thank goodness. But you know, you could see those images, and you know, having worked as a nurse in ICU, the nurses gowned up, you know, top to tail in the most awful, stringent PPE at that time. And I know we all wear PPE in circumstances. And just communicating by eyes and touch, with gloves and everything else, and being able to see that somebody was suffering by deeply acknowledging and looking into their eyes, and being able to say, do you know what, even though you have to degown, you need a break. You need to step out and go and have a cup of tea, and doing something nice like that. And, you know, there was also a very big audit that was done. John might be able to remember his name. He was going to take over the HSE, NHS leader on digital and patient systems in the UK. and he before he did an audit of all the emergency departments across Britain, and sadly he has passed away himself since. He was a registrar when I was in Bagot Street. Do you remember his name? Gentleman?
Yeah, it's Aidan Halligan.
Aidan Halligan, thank you.
Yeah. I
And
met Aidan
Aidan,
once. Lovely man.
an absolutely wonderful guy. And what he did was he went round with a clipboard around all the EDs, and he was asking everybody, you know, what's working, what's not working, looking at the whole appreciative inquiry thing. And he was also asking people, you know, is there anybody here who is part of the team but isn't acknowledged as such? And there was a particular tea lady in a particular ED who was the person who would come up to everybody, and even she might give out to them, and she might say, you have been barking your head off at everybody all day. Here's a cup of tea, go and sit over there for half an hour. I'm pulling you out. And she actually, you know, what they realized was she was actually a leader.
Absolutely, yeah. Isn't that, it's almost a definition kind of
Yeah.
somebody who's leading, you know, through
Yeah.
their actions. Yeah, lovely. Yeah, and I think, you know, a lot of what we're talking about here about it is constructed again as resilience, isn't it? And what are your thoughts? I suppose sometimes we kind of think of resilience as something that are individual characteristics, but it's so much again about the system around you. And I think like your story there showed, you know, that resilience is in the tea ladies and in our patients, and you know, it's throughout the system. And I think it's often just being able to see it and being able to then tap back into it, isn't it?
And look, it never ceases to amaze me that, you know, when I work with patients in oncology, and you know, some people are going through such hard treatments and all the rest of it, and they would still turn around and say, well, look, you mind yourself this weekend, and I hope you have a really lovely weekend. Now, to me, that is huge resilience, being able to step outside chemotherapy and
Yeah,
radiation and be able to think of the person who's helping them.
yeah, yeah. And yet they're helping the system by that little comment, you know, that
Yeah.
everybody's showing that everybody
Yeah.
cares, you know. Yeah,
Yeah.
it's so important, isn't it? There's a
And
nice comment.
I think patients are so aware of
Yeah,
what we do,
yeah,
and very appreciative for you know, the most part. And when people are angry, I mean, I remember as a nurse years ago thinking, it's the angry patient you need to take care of more because they are suffering more. There's
yeah,
something there, and you need to listen to that and ask, how can we help you?
yeah,
Mm.
And resilience, back to that, John, resilience is, you know, something that some people believe is innate. I think we can learn resilience, and look, as healthcare workers, we are really good, generally speaking, at being resilient, but we need to watch that resilience is nuanced, and that it's not just about being able to have a stiff upper lip and manage anything. Being resilient is also being able to speak up when things are wrong. And
yeah,
it's also
yeah,
about being able to allow suffering and allow vulnerability.
yeah,
There's something about that piece about the vulnerability, and I know we said we'd come back to it towards the end.
Oh,
One of the biggest challenges, you know, for a lot of managers is that line between vulnerability
mm.
and feeling that they're going to burden their staff or they're going to overshare in creating that sort of psychologically safe environment. Have you any guidance for leaders within the system as they sort of walk that line between the two, and how do I create a psychologically safe team without leaving myself appear like I'm not able to manage or not able to cope?
Mm. I think sometimes you set the stage by talking about aspects of suffering yourself, and you know, you might say, well, look, I had stuff going on at home, that was causing me pressure, but this is what's happening in work that made me very sad dealing with that. And it's setting that stage of not oversharing, but allowing something to be named, and saying, look, we're not here to fix each other's problems, but there are pathways that can help people if they need support for that. And this is a supportive team, but we are here as companions to listen and to support people and facilitate maybe changes to something where things can be changed. You know, it might be that somebody's saying, look, I've worked every weekend for the last whatever. And I know, and people will laugh, you know, I know certainly from my experience, often if you were from Dublin, you did most of the weekends and you did all of that more so because you felt that you wanted to allow other younger people to go off home to their family for the weekends. So, you know, there was that element of, well, hang on a minute, I've done 10 weekends now. Maybe somebody else needs to step in. And to be able to say that, I need some weekends off. It's okay to say that.
It's really good. There's one other comment in the chat box, just in terms of, it's Margaret quickly had mentioned about thinking about the language that we use could be improved to create better culture of positivity. And it's a really good, I think it's a really good point. I'm sort of reminded of that study. It's a while ago now, but of changing the terminology from near miss to good catch. And it's a really simple example of how, you know, in changing from a near miss to a good catch, the language, the safety, everything changed significantly just in terms of our language. And it probably
Hugely
does impact. Yeah.
Hugely important.
Yeah, I suppose one of my favorite concepts, I suppose, in quality and safety at the moment is the idea of joy in work. And I think this idea of again thinking positively, you know, for patient safety, you know, it's about you know, liberating the creativity that's within people, you know, to bring about innovation and to bring about change and new practice, and that in itself, I think, is something that brings kind of joy to people. But you know, we really need to do this to unleash kind of the potential of patient safety in terms of the ideas and the efforts that people are willing to make, you know.
I think even simple things like bringing in, you know, the Friday joke, you know,
Yeah,
keep it clean, but bring it in. And,
yeah,
you know, just starting positive practices like that that are very simple and human. And it's about
yeah,
sharing our shared understanding of the difficulties, and then looking at, well, okay, what can we all do to mind ourselves? And how can we
yeah.
make coming into work a more pleasant experience?
Yeah, absolutely.
And
Veronica, could I ask you would you read that little piece from David White? Because unfortunately, we're coming to the end of our chat, and I'd love if you'd share it with us, and I think it's a lovely way maybe to conclude our chat.
yeah, it's just a really nice kind of, you know, hits where it needs to be. So it's called vulnerability. It's a little bit of prose from David White. Vulnerability is not a weakness, a passing in disposition, or something we can arrange to do without. Vulnerability is not a choice. Vulnerability is the underlying, ever present, and abiding undercurrent of our natural state. To run from vulnerability is to run from the essence of our nature. An attempt to be invulnerable is the vain attempt to become something we are not, and most especially to close off our understanding of the grief of others. More seriously, in refusing our vulnerability, we refuse the help needed at every turn of our existence and immobilize the essential tidal and conversational foundations of our identity. To have a temporary isolated sense of power over all events and circumstances is a lovely illusionary privilege, and perhaps the prime and most beautifully constructed conceit of being human, and especially of being youthfully human. But it is a privilege that must be surrendered with that same youth, with ill health, with accident, with the loss of loved ones who do not share our untouchable powers. Powers eventually and most emphatically given up as we approach our last breath. The only choice we have as we mature is how we inhabit our vulnerability, how we become larger and more courageous and more compassionate through our intimacy with disappearance. Our choice is to inhabit vulnerability as generous citizens of loss, robustly or fully, or conversely as misers and complainers, reluctant and fearful, always at the gates of existence, but never bravely and completely attempting to enter, never wanting to risk ourselves, never walking fully through the door.
That's really lovely. Thank you. Thank you so much.
Beautiful.
It reminds me of, when Brené Brown talks
Yeah.
about courage, she frames it completely like you've just done there, in terms of understanding and engaging with our vulnerability. And I think that's what's needed, I think, to bring these changes. Veronica, it's been a real pleasure. Thank you so much.
Thank you.
And thanks, Juanita. And we have popped up some, this is just a small number of resources there, and that we think are kind of in this kind of theme of thinking positively for patient safety, learning from excellence, liberating structures, Compassionate Mind Foundation, compassionate leadership there we spoke about, Veronica's paper there, and some things on joy at work, and some nice videos, including from Michael West, and there are several other Michael West videos available. Amy Edmondson's resources in many places, but on ihi.org on psychological safety, and the Being Better Together podcast from the Learning from Excellence folks. And there's some lovely, there's about 10 episodes on that now. So I think we're going to put some more resources up on the website afterwards as well. So Veronica, it's been a real pleasure. Thank you so much. And it's been a great start now to getting our autumn series off and going. So thank you.
You're more than welcome. And, I know it's only a tip of the iceberg, but it's great to be part of this. And I wish everybody well going forward.
Thank you. Thank you so much.
Thanks so much.
I'm going to hand over now to Maureen, I think, who is going to take us through the launch of Walk and Talk Improvement. Maureen.
Good afternoon, John, and everybody online. Hello, my name is Maureen Flynn, and I'm Director of Nursing working with the National Quality and Patient Safety Directorate. And I have the fabulous duty of sharing with you something really new coming from the Directorate, leading up to World Patient Safety Day. So in case you haven't heard about it, World Patient Safety Day is the 17th of September, next Saturday. So we have a new podcast series to share with you. So in the wake of COVID-19 pandemic, podcasts have seen a tremendous growth as a media channel. Audio format is agile and very flexible. It's accessible anytime and anywhere. So as a response to that, the National Quality and Patient Safety Directorate, in collaboration with our colleagues from the National Quality and from Health and Social Care Northern Ireland Hub, have come together to co-design with patient partners a new podcast series that is focused around the commitments in our national patient safety strategy. So there's 6 commitments. The title of the podcast is Walk and Talk Improvement, and it's sharing ideas for safe quality care. Our colleagues in Northern Ireland would be with us today. However, in respect to the period of mourning for the sad loss of Queen Elizabeth, they are not with us today, but will be following up, and we send them our sympathies. So you'll see on the side just our podcast of the slide, the little thumbnail for it, and just to remind us its connection with the patient safety strategy. So I'm going to hand you over to my colleague, Dr. Mary Brown, who's going to tell you a little bit more about what you'll hear in the podcast. Over to you, Mary. Great, thank you, Maureen, and good afternoon, everybody. We're delighted, as Maureen has said, to share with you our new podcast series. And I suppose as a director, we were really keen to embrace this medium as we felt it provides an alternate way for people, you know, to connect and to come together around patient safety topics and hopefully generate additional discussions and conversations. Just before I go into the detail of the podcast, I suppose in being true to QI, we use that very much approach in the developing of the podcast. So a huge amount of planning, testing, and adapting with buckets of learning, I have to say. We did get a lot of significant support and wisdom from Michael Coleman in designing and developing our first 2 podcast episodes. But then I think we certainly did take the learning from that, and we were a lot more independent in the development of our second 2 episodes. And it's fair to say that I think our stabilizers are certainly off now, and we're facing enthusiastically into completing the last 2 episodes in our series. So as you can see, 4 episodes are now available. Our first episode is focusing on the importance of patient partners. That's hosted by Clifford Mitchell, a colleague from Northern Ireland, and he co-hosts with David Milliken, who is a patient partner. Their guests are Carol McCullough, Linda Craig, John, our own John, and Bernie O'Reilly. Then again, episode 2, there's John and myself are co-hosting that episode, and we spoke with Caroline Lennon-Ali, Elaine Fallon, Dr. Leonard Douglas, and Dr. Athenia Shirivaraj, and Lucy Nugent, and they shared with us their stories, their insights, and their learning as to how best to empower and engage staff. Our third episode focused on recognizing the deteriorating patient. It was hosted by our colleague Roisin, and Roisin's guests included Yvonne Young, Christine Sheehan, and Dr. Brian McCluskey. And finally, the 4th episode, No Data Without Stories, No Stories Without Data. Our hosts are again our colleagues Gemma and Grania from the Directorate, and they were in conversation with Gemma Wills, Keith Sinnott, Damien McGovern, and Professor Deirdre Madden. So that's our 4 episodes. They're all available now on Acast. And to give you a lot more information about this, I'm going to pass it over to Shima.
Thanks, Mary. To be honest, that was a very good overview, so I might just be repeating a little bit, but the QR code right there will go straight to our website for the podcast. So if you scan that QR code, you'll go straight to Acast, where we have 4 episodes available. We're also available on Spotify podcasts. So if you just type in Walk and Talk Improvement, you'll be able to listen to our 4 episodes on there and follow and subscribe to us. We are in the process, because we also know Apple Podcasts is the other most popular place to listen to podcasts, but we are in the process of getting ourselves set up on Apple Podcasts. But right now we are available on Spotify and on Acast, and the QR code will take you directly there. Okay, and I'll just hand over back to John.
Thanks, Shima. And yeah, this is very exciting. So yeah, we'd encourage you to use the links there, and please do listen to the podcasts. And I must say we've had good fun making these, and we've learned a lot, I think, as a group. And it's been a real pleasure to do it with our colleagues from Northern Ireland. And a big word of thank you as well to Michael Coleman, really, who guided us through this process. Okay, Stephen, we might pop on to the next slide there. Thanks, folks. Just a quick kind of mention of the Handbook of Patient Safety again. Just lots of Irish input into this, but it's really just to flag it up there as a really practical way. We're talking earlier with Veronica about practices. So this book, I think, is full of practices that make care safer. Next slide there, please. And again, thanks to Stephen for all the QR codes, just to make it easy. We want to kind of continue to get people to engage with the QPS Ireland network map. So if you're not on the map, please use the QR code or the web link there and get yourself on it. And we'd like to know where you are, but also for you to see where other people are and to connect up in knowing who's doing quality improvement around you. So please do join that. Next slide. And again, if you haven't already, again, considered becoming a Q member, maybe now is the time to do it. And again, there's some links there on the Q website. You can find out about applying for membership, and our colleague Caroline Lennon-Nally is available. That's her email there if people are interested in maybe learning a little bit more about the process of joining and what's required. And again, I think just it's connecting with people in Ireland, but also in the Q community. It's the ability to connect with people across the UK as well, people who've got very similar problems to you. So lots of chances to kind of join different kind of working groups and forums there to share ideas and to come up with new quality improvement solutions. Next slide there. And yes, so we're off and started. We're back with you in 2 weeks' time. Again, we've two really great guests joining us from the UK, Professor Joe Rafferty and Amanda Oates from Mersey Care NHS Foundation Trust, big mental health trust in the northwest of England. And they've done a huge amount of work on restorative just culture. And I think that'll be a really fascinating session, just hearing how they've put restorative just culture at the heart of their organizational approach to quality improvement and patient safety. So I really would encourage people to join us for that. And then hopefully on the 11th of October, in 4 weeks' time, we will be coming to you live from the National Patient Safety Office Conference, which is taking place in Dublin Castle, and we'll have the chance hopefully to speak to some of the speakers who are going to be at the conference. Next slide there. And yeah, so finally, just again, you know, when you log out today, you will get a link to a short questionnaire. So please do engage with that. Please give us your feedback and let us know how you thought today's webinar was, and maybe some ideas that you have for future webinars. And if you have any ideas, alternatively, you can just contact Stephen, and Stephen's email is there. And I have to maybe just conclude today by saying a big thank you to Stephen, who's just joined our team and really helped us to put together today's webinar. And also a big thank you to Maureen and Juanita, again, who do all the hard work in the background too. And so I think that's it from us then today. Is it that's our last slide? Yeah. Okay, folks, thank you. We'll see you in a couple of weeks' time. Thanks to Veronica again today, and look forward to seeing you for joining us for Joe Rafferty and Amanda Oates in a couple of weeks' time. Bye-bye.
Take care, everybody.